Hi, and welcome everyone to our first virtual town hall. We hope to address many of your questions that have come to light during this period. We do want to say this is for informational purposes only. This is not a medical consultation, and we encourage you to speak with your medical team about your specific circumstances. Participants are muted in the webinar by default. You can submit questions to us so we can ensure everyone can share in the experience. And we'd like to briefly walk through a short technology overview to get everyone acquainted with the technology here today. Initially, we reserved over 100 seats for the town hall, and as of now, we're joined by over 275 households. So throughout the presentation, we'll be actively monitoring the chats that come through and responding to you there. And we'll be saving questions for a Q&A later. So just to test the chat feature, if you wouldn't mind, we'd love for everyone to chat us by let us know where you're from. So chat into the chat box and let us know where you're calling in from. Great, it looks like it's working. We've got Oregon, we've got Denver, Massachusetts, Michigan, Pennsylvania, Colorado, LA, Indiana. Awesome. Barcelona, Spain. Very cool. So we have a global group here, and it looks like the chat is working well for everyone. So perfect. Feel free to connect with us through the chat throughout the webinar. And like I said, we'll be monitoring questions for you in there. Great. Due to time constraints, we may not be able to answer all questions. However, we will be taking questions down and we'll provide FAQs and follow-up. The webinar also is being recorded, so the information that you are being presented today will be sent out as soon as we possibly can, and feel free to share that with your friends and family as well. If you experience any issues with technology, there's a help article in the chat window for Zoom, or you can chat us or reach out to a member of our team, Heather, at info@histio.org. We'd like to get a better sense of our audience today, so we are going to ask you to participate in a very short poll, which will ask you to tell us which disease most represents your interests today. So in a moment, the poll window will show on your screen, and you can choose your answer, and then we'll show the results. So give everyone a moment to participate. And it looks like we have, you know, every disease represented. So LCH, secondary HLH, we have erdheim-chester's disease, lots around HLH, both primary and secondary, ECD. We have Rosai-Dorfman disease, juvenile xanthogranuloma. Okay, so it looks as though all diseases are represented on the call today, which is great. So we will be addressing all of that with you today. Okay, so really briefly, just wanted to give you a sense of who is on the call before we turn it over to our experts. And so the Histiocytosis Association is a global nonprofit founded in 1986. We are dedicated to raising awareness about histiocytic disorders, providing educational and emotional support, and funding research leading to better treatments and a cure. We also have a medical and scientific advisory committee to assure that our contributions and those of our donors, both conceptual and financial, continue to have maximum impact. The association board established what we call the Medical and Scientific Advisory Committee, where focus is to further advance our efforts to most rapidly and effectively obtain and translate new knowledge in these diseases to benefit the outcome of children and adults. We are also joined today by 4 doctors from the Histiocyte Society. The Society is an incredible association of 200 physicians and scientists from across the globe who are considered to be the leaders and pioneers in understanding and treating all histiocytic disorders. The work of the Histiocyte Society is to continue to advance knowledge around histiocytosis, in addition to a commitment to improving outcomes for patients through clinical research. And clinical research involves the exploration of ways to prevent, detect, or treat disease. For over 30 years, the Histiocytosis Association has served as a partner and primary source of funding for the Histiocyte Society, and together have helped provide support through managing much of the work associated with running volunteer-based nonprofits so that we can focus on research and treatment. We are joined today by several experts in the histiocytosis and infectious disease space. We're joined by Dr. Michael Jordan, immunobiology, Dr. Carl Allen, hematology and oncology, Dr. Ed Behrens, rheumatology, Dr. Eli Diamond, neuro-oncology and neurology, and Dr. Hamid Basiri, infectious disease. I'm going to turn it over now to one of our experts, Dr. Michael Jordan, to kick off our presentation. Thank you.
All right, thank you, Deanna. So just a few basics to start with. So, we are, for the most part, we are experts in the histiocytoses. Most of us are not experts in the coronavirus. We do have Dr. Basiri with us as an infectious disease specialist who can speak to that more. But generally, our focus is on the histiocytoses. So we know the context in which we're talking. But all of us are US-based members of the Histiocyte Society, and we're all gratefully partnering with the Histiocytosis Association over the years. And so I think what's probably true for all of us, whether it be physicians or lay people, is that we're all trying to absorb just a flood of information related to this new virus. But despite the fact that we feel like we're being inundated with information, there's actually extremely very little high quality medical data upon which to make firm recommendations and decisions. So we have to be careful in terms of how we think about this. But our main goal for today is to try to contextualize what is known, what we can say to the histiocytosis community, so that we can bring it to you guys as opposed to what you might just hear in the news. So next slide. And so actually, I'm going to turn this over to Dr. Basiri.
Thanks, Mike. I just want to provide you with some basics just so we're all on the same page, a little bit about novel coronaviruses and some recent publications that were largely observational regarding the impact of the novel coronavirus on pediatric populations specifically. So you have heard about this virus already. You've heard probably several different versions of what it's called, either the novel coronavirus. You've probably heard SARS-CoV-2 or COVID-19 as the way it's been being referred to in the media. Just to be clear, this is a new virus and is actually the 7th human pathogenic virus from the coronavirus family. It was named SARS-CoV-2 by an association that essentially names all viruses now. And the disease that it causes is COVID-19. And actually what we know about the prior human coronaviruses is that the first 4 that were identified, we've known about those for a few decades now. Those largely result in the common cold in a variety of children. So they may have a couple of days of malaise, some fever, not feeling very energetic, but usually recover without any other sequelae, any other complications. The next 2 were a little bit more problematic. So we first met SARS, the brother of SARS-CoV-2, in 2003. It popped up in Guangdong, China, and before it kind of disappeared, there were over 8,000 cases, over 700 patients who died as a result, and some healthcare workers who were exposed who died, with a case fatality rate of about 10%, so fairly high. And then later on in 2012, we found our sort of 6th human coronavirus, and that was MERS, or the Middle East Respiratory Syndrome virus. Both SARS, the severe acute respiratory syndrome virus, and MERS cause pneumonias. MERS actually is still ongoing, and we still see sporadic cases worldwide. The case count is probably over about 2,500, with over 850 deaths, with a case fatality rate that tops 35%. So fairly bad disease to come down with, but it does not seem to be as transmissible as the current version, our 7th brother in this family, the SARS-CoV-2, which is very transmissible, and it primarily transmits via droplets and contacts. So people who spread their oral secretions through cough, through runny nose, through a variety of secretions, and either put them on surfaces that we touch and then touch our faces and mucosal surfaces, or by actually direct respiratory contacts getting on one of those mucosal surfaces. As you have probably heard, you probably know there's no way to escape this. There's been a significant number of infected adults, and some of these adults have severe courses, and it appears that from all the statistics worldwide that we're getting, both from Europe, from China, as well as here in the US, there's a clear and distinct association between advanced age and a more severe course, as well as other comorbidities such as lung disease or heart disease, high blood pressure and diabetes that can also lead to more severe outcomes if one were to be infected and has one of those underlying diseases. On the other hand, what is perhaps a little bit more heartening from our perspective, since we're all work with pediatric populations for a large bit of our time, is that children, even those with immune deficiency or on chemotherapy, seem to be largely spared. And I did want to share with you, I didn't want to get too technical, but I do want to share with you one piece of information that was actually published yesterday through the Mortality and Morbidity Weekly Report from the CDC. This is an experience of about 150,000 cases of COVID-19 patients in the US. So it's sort of like an interim analysis, if you will, or a upfront observational analysis. And of these roughly 150,000 patients, only about 2,500 of them were patients that were less than 18 years of age. That's only a small slice, as you can see. And what's even more encouraging, I guess, is that there only appeared to be about a 6% hospitalization rate in this group, with only 0.6% needing ICU level care. And of the patients, and they didn't have robust data on every one of these patients, but of the patients that they had robust data that were in the pediatric cohort, where they actually could see what their comorbidities were, what kind of medications there were only 10 total patients, not 10%, but only 10 patients out of 350 that were actually on immunosuppressives at the time that they were admitted to the hospital. Again, these are sort of preliminary numbers. This is sort of an interim analysis, and we don't have full robust data on every patient, but the overall trend is suggesting that pediatric populations in general are somewhat spared, and even those who are on immunosuppression may not necessarily have fulminant courses of disease, as we're seeing in the adult population. So I just wanted to give you a brief overview and set the tone about what we know so far about the SARS-CoV-2 and COVID-19 disease before handing it back off to Mike.
Okay, thanks. Next slide. So the question we've all been asking ourselves is, so what should we be doing as a community, as physicians, as family members? And really the number one thing remains for everybody is that we need to limit our exposures to the virus. And that's, of course, by social distancing and careful hygiene. So that's really still the number one important thing I think we all need to keep in mind. But there are a number of other questions that have obviously been surfacing that many of you are wondering about. Is what about therapy for the histiocytic disorders? What should we be doing? And what we can tell you so far is that in this context of very limited data, to date, we don't know of any specific treatment for a histiocytic disorder that is necessarily, is a particular problem for individuals if they were exposed to the COVID-19. I think that, of course, we still have to couch this in the fact that we don't know, there's still a lot that we're learning, I should say. And so really you need to, talk to your own doctor specifically to think about treatment options and treatment course. There is, as you probably have already heard, there is some concern about immune compromised individuals. But as Dr. Bussiri just pointed out, especially if you're talking about children on therapy, this appears to be really quite a very small risk. And so you may have also heard that perhaps is there some sort of histio coronavirus connection. You may have seen in the news that patients suffering from coronavirus may in fact be experiencing cytokine storm, something kind of like HLH. I think there are things to be discussed there. We'll talk about that more in a moment in a following slide. But if we move on to the next slide, I'm going to pass things over here to Dr. Diamond, who I think was also just going to talk about some of these basic issues here.
Yeah, hi, good afternoon, everyone. It's nice to be with everyone on this occasion. One of the gifts of this calamity has been sort of the rapid growth of online and virtual events. So it's I'm sorry it's happening in this circumstance, but it's a nice event to have together. So I just, it's important for everyone to be informed about the way that your histiocytosis and your treatment or that of a loved one, may make you different from everyone else. But I think it's really important to remember that we're probably all more similar to everyone else than we are different, and that measures of hygiene and social distancing are just far and away the most important thing for everyone to be observing right now, really as strictly as possible. And so I just want to contextualize everything that we say with that as a very, very important backdrop. And I'll add from a personal perspective that I had COVID-19 a couple of weeks ago, and I'm just fine. But I know, New York, I know a lot of people who had it and who are recovered. And when you're in that circumstance, you worry not only about your own health, but you immediately have a lot of anxiety about all the people you've been in contact with, and all the little cheatings that you may have done with social distancing don't feel worth it anymore. So, for your own well-being and for the well-being of everyone else, everyone should do the best that they can. And we'll go to the next slide.
Okay, so as Deanna already pointed out, our panel today consists of experts in histiocytic disorders. So Dr. Allen, Dr. Diamond, Dr. Behrens, myself, Dr. Jordan, as well as infectious disease, Dr. Basiri. And so the questions that the Histiocytosis Association has shared with us that they have been receiving from patients and family members can be summed up in this list you see here. So, and we'll go through these specifically in a moment here. But do the histio patients have any special risk for severe COVID-19 infection? Should I stay on my treatment? Should I be concerned if I was treated previously and I'm now off therapy? Could COVID-19 actually cause somehow the histiocytic disorder, whether it be LCH or HLH or one of the rare disorders such as JXG or RDD? Could it cause that to relapse? Does COVID-19 actually cause a cytokine storm or something like HLH? And so we'll try to answer each of these questions in the best context we can come up with. So on the next slide, I think we'll actually start back with Dr. Diamond in the specifically thinking about treating adults.
Yeah, so a lot of the questions that we saw that were posed to the group related to risk of infection or risk of severity of infection for adults with histiocytosis. The one important thing to point out is that there's the histiocytic diseases have a very, very wide spectrum. You can have someone who may have very modest skin disease who has not received any kind of treatment or much treatment, and there may be individuals with very severe disease who've had many years of chemotherapy. So there's a real spectrum of the ways that the disease or treatment could affect your body and your immune system. From limited data, from what I understand from China, individuals with cancer probably have more severe infection than people who don't. I think there is some concern, but there really is no data when it comes to adults per se, and it's really a function of everyone's individual condition and the treatments that they've had in the past. Some questions that I have encountered in my practice, in the last couple of weeks, pertain to: should people start treatment? Should this alter the kind of treatment that they're going to get? While these are very case specific, there are some principles that you could think about. So, one is, how pressing is it to start treatment? Are you treating a modest case of disease or something very severe? Could it wait? If it could wait, sure, maybe it's better to wait. And then, is it a treatment that will affect your immune system? And then sometimes one consideration with different kinds of treatments is not only a function of the immune system, but some treatments, land people with lots of medical visits. And so maybe maybe a treatment should be, delayed if possible, not because of the immune system, but because a treatment may just have you having a lot of doctor's visits or lab visits, which maybe, could be minimized at this time. I would say that, I have not many of my patients have had their treatment interrupted, but if it's been possible to delay things a bit, then I've done that. In terms of should people stay on treatment, the general guidance from the entities like ASCO, the American Society of Clinical Oncology, is that for non-infected individuals, patients should continue the cancer treatment that they're on. That's a general principle. I think for patients with things like erdheim-chester, Langerhans, and Rosai-Dorfman, if you're on a targeted treatment, that's probably more straightforward because those drugs don't affect the immune system very much. Things like chemotherapy, the guidance is that people should, in general, you should continue. There are, of course, many considerations. I've had some patients who were, let's say they were almost done with a course of chemotherapy and they were 9/10 of the way, then I just stopped. In general, the guidance is to stay. But there are certainly instances on, related to people's individual circumstance or treatment that you may want to pause. In terms of people who were previously treated, in remission, there's a lot of variance there, as you'd expect, depending on the treatments that people got. Would I say that someone who had histiocytosis in the past and they receive chemotherapy, is your immune system 100% normal? Probably not, but in some instances, it could be very close to normal. Some chemotherapies, may have a lasting effect on the immune system, even one that, can't be measured with lab tests. This is all just a further testament to the fact that everyone should have, the utmost caution and observance of hygiene and social distancing. There are some, there's no specific guidelines for, for histiocytosis, but the hematology groups, there are some guidelines for many of the different hematologic diseases. I think if there's a question of a subtlety of your case, it would be great to, ask your physician to consult those guidelines and see which of those, in light of your particular disease and your particular treatment, may be most applicable to your case. Go to the next slide.
Okay, hi, I'm Carl Allen, and thanks to the Histiocytosis Association for organizing this, and to the community for sharing your time with us. I recently just did a 5-day stint managing homeschool for my children, so I appreciate the challenges you're all facing to be able to make time to share your time with us. And I think really largely what I'm going to do is, my clinical and research focuses on the pediatric histiocytosis disorders, LCH, JXG, Rosai-Dorfman, even HLH. But I think the message is more or less the same as you've heard from the rest of my colleagues, which is, we're wrestling with this great uncertainty of how COVID is going to behave, how long is it going to last, if one gets infected, how is it going to impact you? And I think because the experience is so new, we don't really know how to digest it all. It's turned the medical landscape upside down, so it's making it sort of difficult to figure out how to navigate the world that we're living in. But I think despite all that uncertainty, the best message is, stay home, wash your hands, don't get COVID if you can help it. But otherwise, the same rules kind of apply. So if you get fever, you'd call your doctor and sort it out depending on your, on your situation. If you have a central line, does that mean you have to come into the ER, et cetera? I think the thing that makes it us have a lot of anxiety is, again, the sort of biological uncertainty we see from COVID, although from all of the data that was just shared and what keeps coming out is that it does seem like this virus is one that attacks kids less. But having said that, we give everyone the flu shot in the wintertime because we'd really rather have people not be infected than be infected. And I think if you were to get this virus, one would kind of manage it in a similar way. So again, let me address some of these questions. So what are the risks of COVID-19 in children? Again, I'm not a COVID expert, but for various reasons that seem to be coming out largely, I think having to do with the kind of strategy this virus uses. It seems that perhaps kids don't have the receptors as much that the virus uses to attack, and then just whatever it is about the immune and metabolic makeup of children seems to be somewhat protective. Having said that, there are some kids who do get sick, and so we need to take this seriously. And I think, perhaps even more serious is that we have no idea how many healthy-looking children have the virus and can spread it to you or to your parents or other people who could get sick from the infection. So I think kids with a history of histiocytosis are the same as other kids, in that the best recipe is to try to not get the virus. Are there special risks for COVID-19 infection in children with cancer or LCH? We don't know that for sure yet, but I think that's a question that we don't want to really ask if we don't have to. So I think, again, if your child gets fever, I would just recommend you call your doctor and we sort it out like you would in any other instance, kind of with the understanding there's this extra risk of this new virus out there that may have some unpredictable behavior. Can COVID-19 trigger relapse? I'm unaware of that. I think there's, again, because the word HLH or macrophage activation syndrome is maybe being used to describe some of the inflammatory responses that some people are having with COVID-19. It seems like, I think the experiences thinking about pathologic inflammation in the setting of HLH and macrophage activation syndrome may be informing how we can manage COVID-19 infection, but I think the converse isn't necessarily true. I'm unaware of COVID-19 triggering certainly LCH or those related conditions, Rosai Dorfman, JXG, ECD. Whether or not it could trigger HLH in a patient who is susceptible, I think is still uncertain. Next question is, should I continue my LCH treatment? So I think as much as possible, I would just, I'm advising our patients to continue their treatments. Our clinics are functioning. We're able to kind of manage. Houston's not hit nearly as hard as New York or some other cities, and so we're able to keep our clinics open with some, again, trying to make precautions to avoid contamination or infection as much as possible. If someone's coming in for their 5-year off therapy visit, we may say, well, let's do that at the end of the summer. We're also working on video conferences or telephone conferences. So I think in cases where those can be managed, I think, again, just sort of minimizing the trips outside your home is generally a good idea. My mother-in-law is getting elective surgery on her dog today. I think that's a really bad idea. I advised her not to do that. It's using up PPE that other people could be using, and it's having two humans come into contact who really don't need to. So I would just say treat your disease according to schedule, but with the caveat that I would check in with your doctor what can be modified. So the question of what if your child develops fever? Well, it depends on the context. I think that the answer to that is always call your doctor and see what they say. And I know everyone has anxiety about their specific disease, their specific biology, their specific family situation. I just say that we're all part of this collaborative team here to help. I think your doctor knows you best. If there's general questions, we certainly are available through the Histio Association to field questions in general, but the best thing for you specifically is to check with your doctor. So thank you.
And then just a few more words specifically about HLH. And one question is that since we know that infections can actually trigger HLH in patients that develop HLH, one question is can COVID-19 actually do that? And the short answer is that anything could, in theory, but there's no reason as of yet to think that it necessarily is more likely to than other infections. So for instance, if you think about the flu is a very common infection, and it, like many things, can trigger HLH, but it's not a common trigger for HLH. And so I'm hopeful, I think I'm rationally optimistic that COVID-19 may be similar to that. Having said that, what has been noticed is that there's a lot of severe inflammation has been noticed in mostly older individuals with severe infection with COVID-19, and that's raised a number of questions related to is there some sort of overlap between this infection and HLH. And as I already said, it doesn't trigger HLH that we know of in the individual that is necessarily susceptible to HLH. But somehow, or in some ways that are not yet understood, the infection itself is quite severe in terms of the inflammation it induces. And I think Dr. Behrens will have a little bit more to say on that in just a second. But actually, one other thing I wanted to mention is that since many patients with HLH have a bone marrow transplant, and those who've been through bone marrow transplant know that, that you're really quite substantially immune suppressed through transplant. You know, our general practice, I think the practice for all transplant units, is to be very cautious and extremely careful about all infections early after transplant. But once somebody is beyond a year or more likely 2 years post-transplant, these sorts of considerations for somebody that's in good health really become more like the normal sort of concerns that anybody might have about infection. And so in the case, if we're talking about young children who've gone through transplant years previously, then they really have no evidence to date to suggest that they should be in any sort of special risk if they're in good health following bone marrow transplant. And so we don't think that there's any particular concern for somebody that is now far from years from transplant. Now, in terms of this question, I don't want to monopolize the floor here, but in terms of this question about the severe inflammation seen in COVID-19, I think Dr. Behrens, you wanted to show us a slide. We can go to the next slide.
Right. So thanks, Mike. So I think, you know, this term cytokine storm syndromes can be very confusing because it's an umbrella term that relates to a whole wide variety of different conditions that all can be very different. So this is a figure from a opinion piece that a bunch of rheumatologists have written. And actually, I just found out that it's been accepted for publication about 30 minutes ago. So this will be available publicly to anyone that wants to read it, to try and put in context at least how a group of us think about where this idea of COVID-19 and HLH and MAS and cytokine storm all fits. So there are cytokine storms that are caused by genetics, and we call that familial HLH. There are cytokine storms that are associated with rheumatologic diseases such as systemic JA-MAS, or that green bubble that you see there. There are cytokine storms that are associated with infections and lots of different kinds of infections, EBV, influenza. So viruses that we've known about for decades have caused things that look like cytokine storm. And then there are cytokine storms that are associated with malignancies, that sort of orange bubble that's in the upper left of the screen. And we sort of drew this bubble of COVID-19, the red circle down at the bottom left there. It's clearly a virus-associated cytokine storm. It appears to be very different from what we think of as being systemic JA-MAS. It appears to be different from what we call familial HLH or EBV HLH. And again, I should caveat this, but this is just based on the early data that we've seen from China, the early data that we've seen from Italy, so some more data to come. But based on what we've seen, while there are features of cytokine storm in the sense that patients with COVID-19 severe disease make cytokines at elevated levels, their ferritin levels seem to go up, they get some changes in their platelets, the overall picture doesn't look, and I think most experts that have seen this would agree, the overall picture doesn't look like what we traditionally call familial HLH or systemic JA-MAS. And what it looks like the most, if it looks like something, is acute respiratory disease syndrome, or ARDS. And there is a form of ARDS that's associated with a cytokine storm in patients that have cancers that get a special kind of therapy called CAR T cells. So if this reminds us of one particular kind of cytokine storm, it is this cytokine release syndrome, ARDS, that's seen in this very specific population of patients that have cancers that get CAR T cells. And to some extent, that's where the excitement surrounding IL-6 blockade treatment has come from, because that has been an effective therapy in that population. Whether it's an effective therapy for COVID-19 is still obviously an active area of investigation, and we'll have to see how those studies pan out. So I thought this was just sort of a useful cartoon to show, because a lot of the questions coming in chat, a lot of the questions that we're getting from our patients relate to the fact that we're reading about COVID-19 MAS or COVID-19 HLH in the lay press. And I think it's important to note that while it shares some features, it's not the same thing. And I don't want folks to be sort of putting it all in that same bucket and worrying themselves unduly, because I think what we're talking about is a very distinct cytokine storm syndrome that belongs in its own group. So I think I'll just sort of stop there. I'll pass it back to Mike. And then obviously if there are questions about what I said, you can certainly put them in the chat.
Mm-hmm. Yeah, and as we started with, there's still a lot to learn. There's still a lot of research that needs to be done. And I think actually Dr. Basiri shared a chat text with the whole audience about some efforts along those lines. But I think that stay tuned. I would say that over the next year we'll know a lot more. But I think we all agree that this is not that the COVID-19 sort of inflammation is not the same thing we see in classic HLH, and that probably these really should be quite different thought of as completely different things, even though they certainly have some similarities. So our goal was to try to contextualize the questions that we have been hearing, either individually or from the Histiocytosis Association, hopefully we've done that as best we can for the variety of sort of concerns that are out there for the different sorts of individuals or families affected by histiocytic disorders, and hopefully we've encouraged you guys in a positive way to not be worried about things that perhaps that we shouldn't be worried about, but of course to be concerned about things that we should all be concerned about, including trying to limit our exposure to the virus for our sake and for our loved ones' sake. And so I'm gonna actually turn the slides, or turn the talk back over to Deanna from the HA.
Thank you so much, Dr. Jordan, and thank you to everyone. This has been incredibly helpful and informative, and there's a lot of engagement from the community. A lot of questions came through. And actually, I do want to ask Dr. Basiri to come back to the floor just to share a little more about what you did say, because we weren't sure if that the response to the question posed about research, clinical trials and research actually made it to the full audience. So if you wouldn't mind just coming back on and just sharing that out. The question was if there are any plans to begin a research study to address the COVID risks on Histio patients.
Yeah, I tried to answer two different questions. One was basically, are we going to be able to tell for children who have histiocytic disorders, variety of histiocytic disorders, whether there's a higher rate of them needing to be hospitalized due to COVID-19 infections? And in response to that question, and hopefully I understood it correctly, I will say that the Pediatric Infectious Disease Society members, a number of them from a number of different institutions, including CHOP, St. Jude's, Seattle, and others, all participate in putting together a registry, a REDCap registry that has a common entry pathway to identify some very, very basic measures, including age, sex, COVID positivity has to be confirmed, and how that's been confirmed. And then there are divergent pathways or a branching tree essentially to collect more data about each individual patient, including their immune status. So are these patients who are potentially receiving chemotherapy? Are these patients on any kind of immunomodulators or immunosuppression? Are these patients who have had prior transplants, either solid organ or bone marrow? So on and so forth, and get a collection of the different types of comorbidities, which then funnel each of those patients down different pathways and ask further questions in order to try to put together as much data about the entry points for these patients and the potential for then those investigators who are entering that data to then go back later and to put in some outcome data. And so the hope is that over time, as this registry builds, either through interim analysis or final analysis in a retrospective manner, one could actually assess or have a sense of at least the US experience, what percentage of patients with a variety of different disorders and or receiving different immunomodulators may be getting admitted, and is that rate something that we believe is overrepresented or underrepresented? So that was in response to the first question. The second question, I think, had to do more about previously healthy people that appear to come down with relatively severe disease. And certainly we've heard a number of cases about it. Some of us have seen some of that. And the question was, is a research being done, or is there research underway to figure out why that would happen? And yes, the answer is that the NIH and a number of other individuals, people in the primary immunodeficiency community and immunologists are putting together studies to look at what are called whole exome sequences or DNA sequencing from those particular individuals to figure out if there's a common thread or if there are common gene variants that are predisposing some of those patients to have a potentially more severe outcome than would be expected based on their age and lack of comorbidities. So I hope I answered those two sets of questions appropriately for the people who are interested.
Thank you so much. We really appreciate that. A couple of other questions I'd like to pose. One of them is, does pulmonary LCH make it any more difficult for recovery or to breathe during, I guess if you came down with COVID-19, would it make it any more difficult to breathe if you have pulmonary LCH?
Any answer to that I have is sort of inferred and is a guess. And I would think, I'm concerned about my pulmonary Langerhans patients, especially the ones with severe pulmonary LCH. They're the ones that I've been calling and yelling at to stay home. Not because it's Langerhans, but because it can be a very severe lung disease. So, I do have particular concern about pulmonary LCH patients, who have bad lung dysfunction.
Yeah, I think I echo that. I mean, there's no, I'm unaware of any single case of a patient who's been infected or had problems, but just, patients who have lung disease in general seem to be at risk for having a bit harder course. And so I would just say if your child has pulmonary LCH, it's probably good to be on sort of extra super lockdown.
Thank you. And then just a clarifying question, I think, in relation to the slide that we're currently on, wanted to know that if we can clarify that the COVID-19 cytokine storm syndrome is not the same as the HLH cytokine storm syndrome.
I personally consider them to be completely distinct entities. I don't know if Mike wants to throw in his opinion on that as well, but on the basis of the data that we currently have, they do not appear to be the same thing to me. So I consider them to be completely distinct.
Yeah, I agree. They do appear to be different. When we bring up the fact that they have overlaps, and is because that maybe some of the same medicines that may be helpful for HLH in some contexts may also be helpful for the COVID-19 inflammation. But that's not to say that they really are. I think most everybody agrees that they are distinctive despite having some similarities.
And can I just jump in, because something just popped up about IL-18 MES ILD. So just to echo what Dr. Diamond and what Dr. Allen both said about pulmonary disease in their respective conditions, I would argue it's the same is true for the ILD systemic JA patients. If you have a pre-existing lung condition, I think all the more reason to stay at home, wash your hands, and try not to get the infection, because we don't have data, but I have to presume that if you have an existing lung disease and you get a viral lung disease on top of that, that will not be a good combination. So the most important thing is to prevent your child from getting the viral infection.
And Ed, if I can tack on to that, so it's true that we don't have robust data, but from that report that I was telling you about that just got published yesterday, of the patients, of the pediatric patients who were admitted to the ICU, a large proportion of them, a significant proportion of them, I should say, did have some of the same things that we see in adults: cardiovascular disease, hypertension, and actually one of the main things that was noted in that is asthma or lung problems. So while that doesn't necessarily, I can't really comment on LCH or other ILDs that affect the lung, it is true that if you have pretty severe asthma, then you may stand a chance of developing more severe disease even as a child.
And one other point along these lines, I saw a question scrolling by, which is sort of a question about research, but also a question regarding this overlap between COVID-19 and the inflammation that we see in HLH. And the Histiocyte Society has issued a statement publicly encouraging physicians of all sorts to look for unusual inflammation. And I think because we think this is probably the beginning point for how we can begin to understand what is it about this disease, what's important about the inflammation, and how might it have some similarities with the sort of inflammation that we deal with.
And the rheumatology community has, in alignment, put out the same statement. So I think that the process of educating ER docs and ICU docs and other physicians is definitely underway. There's a lot of us that are engaging those professionals.
Thank you. So one final question. Are we treating pediatric patients with COVID with any experimental medication like hydroxychloroquine?
I can probably at least start to comment on that, which is to say that there are children that are being treated with hydroxychloroquine. We've seen that both at our institution as well as other institutions. The truth is we still are not sure, because these are not treatments that are done under the auspices of a randomized controlled study, as to whether they are benefiting from that. But especially in children who appear to be worsening and who are potentially not candidates for any other type of therapies, including things like this antiviral remdesivir or other immunomodulatory type therapies, we have seen hydroxychloroquine being used.
And if I just want to jump in real quick on that, hydroxychloroquine being a medicine that I prescribe all the time as a rheumatologist, I don't think anybody should be going out and getting a prescription for hydroxychloroquine to try and prevent getting coronavirus infection. I don't think anybody should be going out and getting a prescription of hydroxychloroquine just because you've tested positive for the COVID-19 infection. And also, in part of all of us doing our part, this is a medicine that's critically important for our lupus patients so that they don't flare. We know quite well from studies that have been done years ago that if lupus patients stop taking their hydroxychloroquine, their disease will flare up. And unfortunately, now most of our lupus patients are unable to get refills of their hydroxychloroquine because of other folks getting the medicine and hoarding it. There's now a nationwide shortage, which is causing trouble for our lupus patients. So I think it needs to be studied and needs to be studied responsibly. But I don't think that anyone should be running out and getting a supply of hydroxychloroquine to somehow try and prevent them from getting COVID-19.
I think I'd maybe just add on to that, just irrespective of the agent that's being analyzed. I think the Histiocyte Society, I think, has made so much progress in treatment of children and adults with histiocytic diseases because we've been able to ask research questions, and we've had generous community who has agreed to participate in that research and support that research. And that's the only way we'll get beyond sort of faith-based approaches and find out what's really best. And it seems like this disease is particularly has a lot of variables, so it'll probably take, it's not going to be a straight path, but so if given the opportunity, I think participating in research or a research study is always, it helps the community if it's something you're comfortable with.
And it's not true that lupus patients are not coming down with COVID-19. There are multiple documented patients who have taken hydroxychloroquine as part of their standard medicines that get COVID-19. So, so despite what some folks are saying, that's just not the case.
Great, thank you. And we have seen a lot of questions come through, a lot of very great questions, and just in the interest of time, do want to just let everyone know that we will go back and review all of your questions. Also know that our physicians have been monitoring the questions throughout and have answered some of them in part of the conversation. If anyone, before we move forward, if anyone on our expert panel has any other questions that they'd like to touch on, we definitely have time for one or two things before we wrap up.
I can, sure. I've seen some of the, some questions sort of fly by that I'm happy to just sort of address as one-off. I think that we've pulmonary LCH, Langerhans affects the lungs more than the other adult histiocytoses, but I don't think that anything that we've said, all of that would be just as true about pulmonary Rosai-Dorfman or pulmonary ECD, that would hold the same. Those are just less common in those diseases. I can't see any reason why COVID infection would lead to relapse of any adult histiocytosis. I can't think of any reason that would be the case. It's a very, if you're someone who's in remission, you don't want to relapse and you don't want to take a risk of that. But I can't think of any rationale why that would be the case. And what else did I see? I have seen, not in the context of histiocytosis, but I've seen some caution on the hematology guidelines pages about use of rituximab. So I think for a patient who's on rituximab, you may want to think very carefully about how much it's helping, because that may be something that's worth stopping or discussing, pausing right now. And then the last thing I saw, there's no reason to think that there'd be an interaction between COVID and neurodegeneration in LCH. Someone with any neurologic illness, may have a worsening of neurologic symptoms if you have any infection, but I wouldn't see that there'd be any sort of true interaction between the two processes. So hope that cleans up a few of the questions.
I saw a couple of really tough questions about specific, family and health circumstances. Asking, how, do you isolate it at 1 or do you isolate it at 10? That's something that's just really impossible for us to generalize. I think that only you can take the kind of the equation of all the factors that go into your family and your health and make those decisions. But I think that Eli's experience and comment about New York is certainly poignant. In Houston, we're seeing far less COVID. And so, when you're driving into work in the morning, it looks like a regular day. The streets aren't empty. And so I think each community is sort of managing this differently, but I think it's clear that the risks are real. So whatever you can do to mitigate those risks, I think I think being on the side of caution is probably good, as much as you can do it, but it's really impossible for us to give you specific advice about how, whether to send your husband away or not.
Carl, the only thing I want to add is, I would maybe a little caution against, I'm not saying that you said this, but it made me think about it, against decisions based on density of infection where a person is, because that can change very fast. So, I wouldn't, everyone should, act as though, there could be an increase, within a week or two. And so I would just sort of have that as a caution.
Yeah, that's an excellent point, Eli. I was really kind of more just commenting based on what people are doing more than
no, it made me think about it. That's why I said
what they should do. There's a lot of ways. If we could kind of be armchair, if we could go have a beer with Dr. Fauci, I'm sure we'd love to talk about different strategies and things we could do. But we're managing the world we live in, and I think minimizing your risk as much as humanly possible is the one thing you have control over.
And there was one question, maybe a clarification that I could add relative to what I mentioned about bone marrow transplant in terms of immune deficiency regarding around bone marrow transplant. So as everybody who's familiar with BMT knows, is that around the time of transplant, there is quite substantial severe immune deficiency, but that normalizes over time. And sometimes individuals are left with some residual mild immune deficiencies, like they might need to stay on immune globulins like IVIG, things of that sort. So in general, I think my advice is that what I'm telling my patients is that they've been through transplant more than a couple of years ago and they're otherwise in good health, and even if they have, say, some mild persistent immune deficiency, as long as it's mild and they don't have things like chronic graft-versus-host disease, then my advice to them is that, especially as a child, their risk is probably similar to other children at that point. And so there's not a reason for extra worry remotely from transplant if somebody's otherwise in good health. And then there was a question about face masks, and I just realized that hanging on the wall here is my extra N95 from my basement, from my wood shop. So you know, I think whatever you can do to minimize your risk or minimize the risk of transferring or of spreading the infection yourself is a good thing. And so I personally like the idea of everybody wearing masks as much as possible. But remains to be seen, obviously, how much of an impact that'll have.
Can I just say one thing about masks from an infectious disease standpoint, which is, I think, important to consider, is that sometimes we think about masks and kind of reflect on the use of masks as adults. And as adults, we can probably train ourselves not to fidget with our masks, not to touch our nose and try to adjust things, not to touch our eyes. I think the use of masks in children can be a little bit more problematic, because teaching them those things and getting them to not touch their faces and their mucosal membranes is quite difficult. And a mask in and of itself can sometimes in pediatric populations be a source of wanting to touch the face even more. So if you're using a mask for your child, and I'm not saying you should or you shouldn't, just be cognizant of the fact that that might promote them to actually touch various surfaces and then touch their eyes and their nose and their mucosal surfaces at an even higher rate. So just be wary and cognizant of that with respect to use of face masks in younger children. Older children and adults are probably much more trainable potentially to properly use those things.
Well, thank you all so much. I really appreciate it, and really appreciate you helping out with looking through the questions and helping to address everything with the community, taking the time to spend with us today to go over all this incredible information. So thank you so much. And we understand how important it is to make sure that we provide the most up-to-date information. And so in an effort to support all of you, the Histiocytosis Association has compiled resources into what we're calling our COVID-19 Histio Hub. You can visit this page. We're actively curating articles and updates as we see them, and it'll allow you to stay informed on COVID-19 and find helpful resources for your family while staying home. Also, you can get involved this time by joining our Histio stage, which is a forum where the community can share fun videos to spread some joy, and we'll share those performances out on Facebook and on our website as well. We've moved our events virtual for the time being, and so if you'd like to get involved in our upcoming Histio hike, that's on Saturday, April 25th, and you can visit histiohikeshenandoah.org to register as a virtual hiker and join us on the 25th as we all help raise awareness and lead closer to a cure. And then there are also additional ways to support, so you can utilize Amazon Smile if you'd like, or visit our website, www.histio.org, if you'd like to participate in learning about more information, to register to gain access to additional resources on there. Also can visit our Histio Hub, just many different ways to support and give back. And if we don't have your email address, please stay connected. Let us know by emailing us at outreach@histio.org, and you'll be getting updates on hopefully future events similar to this one, where we can bring the community together, especially now as we have access to being able to provide more virtual resources, more virtual opportunities to connect, and seeing all the questions that have come through from the community as well. We will we will definitely be considering doing more of these in the future. So please get connected, let us know your email address, or visit us on social media so we can continue the conversation. And one final note before we close, because today is World Health Day, we did just want to acknowledge and express our gratitude to those who are on the front lines day in and day out, and especially now, to all of our doctors, nurses, midwives, medical personnel. Thank you for all that you do. And thank you so much to our amazing panelists as well, Dr. Diamond, Dr. Allen, Dr. Jordan, Dr. Behrens, and Dr. Basiri. We really appreciate you taking the time to spend with us today and to share your expertise in all these different areas to address the questions that we've been receiving and questions that have come up on this webinar as well. So thank you so much to everyone, and we wish you all good health, and we'll talk to you soon.